So I wanted to go through today to explain why IHPA is undertaking an evaluation, how we're going to do that, and just update you where we're up to. I'll go through some background and some context, and Peter and Tony will go through the logic behind the approach and some of the detail in the framework in particular. So we've commenced an evaluation program to understand the impacts of the implementation of the National Activity-Based Funding System. And our objective in doing that is to understand the impacts so that we can continuously improve the national ABF system. Focusing on the first 4 years of implementing national ABF, we want to assess the changes that have risen during these years. We're also examining the impacts on data collection and the use of data in particular, which I'm hearing more and more in the last few days about the use of data in particular coming through. So, framing the purpose of the evaluation, we thought that it essentially wants to answer two questions, and the two questions are: what are the impacts of the implementation of national ABF on these outcome domains, these 6 outcome domains up on the slides? And each of these domains trace back to the National Health Reform Agreement, so we're grounded in the context of why we're here. So we're looking at efficiency, we're looking at efficient allocation, we're looking at transparency, sustainability, quality, safety, appropriateness and access. Many of you in the room would be familiar with those objectives coming into the National Health Reform Agreement. And then with all of that, and Tony in particular will give you a flavour of the 36 indicators that we've developed to measure the impacts in those outcome domains. We're looking at the implications for continuous improvement in the national ABF system. We thought it was smart to split the evaluation into 2 phases, and phase 1, which is what we're talking about today, includes the development of the evaluation framework methodology and the establishment of a baseline. Phase 2 will use the evaluation framework that we've developed in phase 1 to undertake the actual evaluation, looking at the impacts over those first 4 years. Almost a year ago, we engaged KPMG and the University of Melbourne in a consortium to undertake phase 1 of the evaluation. The evaluation architecture also includes a steering committee with representatives from jurisdictions, and we also have stakeholder representatives on that steering committee as well. And as it says there on the slide, the pricing authority is yet to determine when phase 2 of the evaluation will be undertaken. One of the questions we got frequently sort of in August and before, and then through to the end of last year, was relating to clarifying what the evaluation is and is not doing. So I thought I'd get that out here today. So in particular, the National Health Reform Agreement refers to undertaking a review of the NHRA, possibly in 2015-16. That's not what we're doing. We're doing an evaluation of the impacts of national ABF. This is different to that. Similarly, we're not doing an efficacy review, and we're not doing a cost-benefit analysis either. Impacts and changes arising through the years of implementation. That's what we're focusing on. I'll hand over to Peter Tyler from KPMG, and he'll talk to you about the approach for developing the evaluation framework, and then Tony Scott after that will get into further detail. Peter.
Thank you, Luke. The approach that we took to designing the framework was to adopt a program theoretic approach, which many of you have been in the health system for a number of years and would have come across that sort of approach in a number of other evaluations. The program theoretic model that we adopted summarises the areas of potential impact, and Luke has just listed those a moment ago, and also describes the mechanisms through which those impacts might eventuate. The study design itself, the methods will largely comprise quantitative analysis of administrative data and related data sets, and qualitative analysis of primary data collected through methods such as surveys and interviews, and I'll say a little more about that in a moment. The quantitative analysis will inform whether ABF has had an impact on the primary outcomes that are being posited as potential outcomes through the framework itself. We've chosen a difference in differences method, and Tony will speak a little more about how that works and how we envisage it operating within the evaluation itself in phase 2. So I won't steal his thunder. I will say, though, that the method itself has been used internationally for similar evaluations around hospital funding, and particularly around activity-related funding models. The primary data collection methods I just mentioned, we'll be doing surveys, stakeholder consultations. The primary focus of those will be around contextual and environmental information, as well as trying to understand the likely mechanisms through which any impacts we or whoever the evaluators may be might observe in the various indicators that have been selected for measurement. The intent there is to try and understand why the policy has or has not had an impact, and that will be essential in any interpretation and attribution arguments that arise out of the evaluation in phase 2, and consequently for developing future policy. We initially developed an options paper, which we then consulted against and developed a set of potential indicators. I won't say any more about those. Luke has described the areas. Tony will speak a little more about the detail there. We then moved on to undertaking baseline analysis, which has principally been focused on the feasibility of implementing the approaches, the indicators and the methods that have been proposed in the draft framework. The baseline analysis has used a range of national data sets, and there are the usual suspects in there that many of you would be aware of: admitted and non-admitted activity data, costing data sets, the NHCDC, expenditure and establishment data as well. So those sorts of data sets that with which many of you will be familiar. The feasibility of applying specific analytical methods such as regression modelling have been assessed, and we also considered things like what are the limitations of the data to actually deliver on what the evaluation is aspiring to do, both at that general level and at the specific level of particular indicators. You know, does the data truly support measuring this indicator for the purpose that we need to apply it? We also looked for artefacts, so changes in counting rules, changes in definitions that have already happened leading up to the implementation of activity-based funding, and areas of risk to future utility of the data. So trying to anticipate some of the issues that might arise over the next few years as the landscape continues to evolve. The surveys that we've undertaken in the baseline process have been aimed at establishing baselines for certain indicators, and the target groups that we surveyed were hospitals and local health networks. They were surveyed particularly focusing around their capability for use of activity-based data, as to which Luke alluded a moment ago, and their general capability around activity-based management and funding. That baseline is intended to be there for a future evaluator to use, clearly. The baseline survey also identified some issues with the survey approach, and they've been detailed and included in the draft framework. We ran a series of open forums with jurisdictions, and thanks to the states and territories for their collaboration and cooperation around running those. And using those, we again collected a bunch of qualitative baseline data around knowledge and use of ABM for a broader population than hospitals and LHNs. And as a result of the baseline analysis, we've produced a revised draft evaluation framework. Oh, fabulous, I got the right button first time. The outcome domains, Luke has already listed those, but I'll just quickly repeat them so that people can cement them in their minds. Efficiency of health services, the efficient allocation of resources, transparency of funding arrangements, sustainability of financing, the quality, safety and appropriateness of healthcare, and access. So those are the outcome domains that were defined in the model. The mechanism is about the way in which activity-based funding is expected to affect each of those outcome domains. The theory of change is essentially the description of the intermediate changes that one might expect to see as that mechanism of change operates. And the dependencies are about environmental, contextual, other factors that might affect whether or not change happens and how it happens. As an example, for the domain of efficient allocation of resources, the logic model talks about the mechanism operating through the use of price signals under national activity-based funding, and also operating through the mechanism of access to improved and enhanced information to allow more informed decision making. The theory of change that's attached to that is that local health networks will actually respond to price signals and use that to inform and assess how they provide care, where they provide care, and what their service model look like. And I was encouraged by the previous presentation that sounds like exactly what might be happening, so our theory may well be validated already. For that particular domain, the dependencies that we've identified are around the local health networks actually having the flexibility and the capacity, capital, staffing resources, the physical capacity to actually modify their service arrangements and do the things that they think need to be done to change their models. I'll now say a little bit about some of the qualitative things we've done. Well, as I said before, we surveyed local health networks and ABF funded hospitals, and we asked them a range of questions around their use of ABF already and what they anticipate that use will be in the future at that local health network or hospital level, how their capability and capacity around activity-based funding and, again, as Luke said earlier, use of information is changing or how they expect it to change, with a particular emphasis around classification of activity, the costing of activity and the counting of activity. We also asked them about their use of ABF more generally in decision making and how they see or are seeing the impact of national activity-based funding policies and practices on their operational decisions and their ongoing financial management processes. In addition to local health networks and ABF funded hospitals, we also surveyed block funded hospitals. We asked them about what impacts they were experience, if any, or expect to experience as a consequence of national ABF. We also asked them some very specific questions around things like inter-hospital transfers and patient flows more generally and how those might be affected or are being affected. We had interviews with state and territory representatives as part of the baseline analysis around the use of ABF as a management tool at their state level and territory level, about understanding how they have gone about implementing ABF arrangements under the national framework, particularly around their alignment or otherwise of the state's approach to the national approach, the pricing formula that they use and the national formula, activity target policies, the use of block grants, transitional arrangements to bridge between old arrangements and full implementation of ABF, and any changes in governance and performance management with local health networks and with chief executives. We also ran a series of open fora. They were open to a number of participants. We got clinical representation, health service executives, state and territory representatives again had a chance to participate, and peak body representation. We ran those in most states and territories, and they focused again on getting that broader sense of the next level down from LHN and hospital management about the knowledge of ABF, knowledge of the change and the transition to the new environment of ABF funding, and how that is impacting on their daily practices and activities. I'll now ask Tony to give us a little bit more detail about the difference in differences method and some of the early baseline insights.
Okay, thank you. Right, so to evaluate ABF, I guess we need a good study design. And the main methodology looking at the quantitative data is uses difference in difference to study design. There's a number of aspects to this, which I'll go through. The first thing is that in terms of that bottom line on the graph there, if we think of an intervention group, those who've been exposed to ABF, it's very hard to get another comparison group or a control group which hasn't been exposed to ABF, because obviously it's happened everywhere now. So that's the first issue we had to face. We can just look at the intervention group, but then it's very difficult to actually know whether any change we observe over time can be attributable to ABF, rather than just general trends happening anyway. So in the evaluation framework, in the initial draft of that, we suggested that Victoria and South Australia would form, hospitals in those jurisdictions would form the comparison group, because they have had minimal change. They've already had ABF for quite a long time, although South Australia has had a bit of a rebirth. But certainly to compare states who've just taken on ABF with those who've had it for a while will give us a comparison group where there's been minimal change. So that's our thinking behind that, and there's various issues to do with how we look at that. And I think how we implement this in terms of difference method is to really to take, if on the graph there you have the difference between A1 and A0, which is just the difference in that particular outcome, which in this case is risk-adjusted rates of in-hospital mortality before and after ABF, and compare that to the similar changes in the intervention group. So the difference between A1 and A0, the difference between B1 and B0, and then we take the difference between those, okay? And then that gets rid of any trends which may have influenced that, so we get a more attributable measure of the effect of ABF, which is D star in the picture there. Now, of course, we'd never get straight lines out in practice, do we? The lines aren't straight. They're all over the place. So what we just sought to do in the baseline analysis is with the 36 odd, well, not all 36, but a lot of the indicators that we have, to get data on that, to calculate national trends in those indicators over time, and to look at each indicator in turn and work out, well, you know, can it be measured? What are the issues with it in comparisons? Are there enough? Is the sample size good enough? And are there any other particular data issues that indicator which may lead us to recommend sensitivity analysis or other kinds of ways that we can examine the robustness of the results of this modelling to changes in some of the definitions. So the domain indicators, now a lot of them within each of the domains, some of them use the quantitative data from a lot of the national data sets that are available, and some of them use data from the surveys and are populated in other ways. So I think we use a range of the data sources that we have to try and assess overall the impact of ABF on each of these indicators. And these indicators are, you know, overall, some of them are easier to measure than others, and so there are a lot of data issues that we need to consider, and also that we need to highlight that the evaluators should consider. So efficiency of health services, we've got relative length of stay index, you know, we've got cost per NWOW and different versions of that, and We've got use of ABF as a management tool, which I'll come back to in a moment. And certainly the quality and safety, we've got 16 indicators following the national approach to developing these indicators, which you're going to hear about after our talk. And also access to care in terms of waiting times. So I think there's a lot of different things in there that we're looking at. Many of that you will be familiar with. And we've really tried, at least with the quantitative data, as I said, to calculate those at national level to establish a trend from 2008-9 onwards, as much as we can for those indicators, and to assess what's going on with those indicators. So KPMG have previously developed a measure of activity-based management capability, which is a survey-based method. So this requires surveys of hospitals. And that really tells us about whether the hospital has the systems in place, the finance and costing systems and the management systems to be able to use ABF data and ABF itself as a way to better manage hospitals. And that's a key mechanism that the ABF might work. So that's something that's reasonably new. But also we've got, I think at the moment, 16 different indicators on quality and safety in healthcare from the high priority complications list, which we're going to hear about. And we've aggregated those as well to kind of an overall measure of quality and safety events. So again, we're tracking those over time nationally and then judging whether those particular indicators are suitable to be used in the analysis that we propose. And remember as well, I think we've tried to follow as much as we can national definitions for those indicators, but often, I mean, we're using those indicators for a different purpose usually than they're being used or recommended for nationally. So there are some differences which we will certainly highlight in the report to make it clear exactly how we've done it. Some early insights from the baseline analysis. Well, part of it is that really the logic model that we propose in terms of the theory behind it is valid, it's consistent. We in talking to people across jurisdictions and in interviews, it's really consistent with a lot of the views about how ABF might have an impact. So that's good. Difference methodology is a stronger study design. It's not perfect, it's not a randomized trial, but nevertheless, I think it is a stronger study design we can use given the context, given the data that we have. And as I said, a lot of the recommendations in the framework document will also have recommendations for particular sensitivity analysis that would need to be carried out by the evaluator to just make sure that the results are robust to differences in definitions and other issues that might affect changes over time, such as difference in coding practices. The majority of indicators are relevant and feasible, so we were able to calculate them. Some of them we weren't because we didn't quite have the data that we wanted, but that data is still available. So they're technically feasible, and for other indicators, the data just isn't there. But for most of them, within each domain, we're going to be able to say something like each domain. The qualitative methods were very useful, of course, to really add the context to help work out for example, if the quantitative analysis finds an effective ABF or doesn't find an effective ABF, then why? That'll be the next question. What is it about that ABF and how it's been implemented that may lead to those results? So we're really trying to I guess, coordinate the qualitative and quantitative analysis to help them reinforce each other. As I said, there are a range of practical implications and data issues which we're identifying for each of the particular indicators. A lot of those will require sensitivity analysis that we're doing now to try and work out, well, can we really use this? But also some sensitivity analysis we can't do now because we're not doing the main evaluation, so that's up to the evaluator to be able to look at and really assess whether these results are sensitive to some of these issues. Okay, back to Luke for next steps.
Thank you, Peter. Thank you, Tony. So very briefly, next steps. So the team are in the final stages of doing their analysis for understanding the baseline. We've got the framework methodology. It's been tested as the team were talking about. that work's nearing completion, and then over the next few months we'll go through the process of going through the steering committee and other committees as well, and up to the pricing authority for consideration later on this year, and the authority will consider when to progress with phase 2 at about that time. So hopefully we gave you a good understanding of why we're doing the evaluation and how we're going about it, with quite some detailed thinking and approach going into that, and giving you a flavour of where we're up to. So thank you.